I want to move to kidney cancer, if I may. I want you to start with SUNNIFORECAST.
Great name.
It was a sunny forecast. It was also a bit of a lucky study in terms of, it was a brilliant German study, investigator-initiated, thought to be impossible to do.
Yeah.
Papillary renal cancer, randomized trial, non-clear cell. Non-clear cell. I don't love the term non-clear cell. I'm trying to get it out of my mind. So, non-clear cell renal cancer, massive German investigator undertaking, actually opened all of Europe, of the UK and France, and brilliant from the investigators. So I think they should be congratulated, and I also think it's practice informed, if not practice changing. What do you think? What did the results show?
So we knew that immune therapy had activity in non-clear cell, broadly speaking. David's KEYNOTE-427 cohort B with pembrolizumab, with response rates in the 20-ish, maybe 30%. And so, there was definitely
29, I think, in your
29.
slide. Yes.
Thank you for remembering. There was definite activity, but immune monotherapy wasn't really a thing in non-clear cell. Ipi-Nivo didn't really have much. There was this Checkmate 920, I think, that enrolled some non-clear cell, had a cohort, if I remember, and it wasn't much, right? And I certainly wasn't using Ipi-Nivo for non-clear cell before SUNNIFORECAST. Then, as you say, it was Ipi-Nivo versus standard of care, which turned out to be largely single-agent TKI. Only 17 patients who got IO TKI. 60% papillary, I think 20% chromophobe, and then a bunch of, other rare histologies, hard to say much about. They chose a landmark OS at 12 months as their primary endpoint. Still not quite sure I understand the rationale, but let's take it for what it's worth.
I think the numbers needed are lower rather than doing a hazard ratio, because the hazard ratio was 0.86.
Sure. Well, I understand the strategy to do it, but I guess I'm talking about the clinical relevance.
It's a randomized phase 2, not a randomized phase 3, and so it's a positive randomized phase 2, and that's why I think it's practice informing rather than practice changing.
Agreed. So at 6 months you started to see the curve separate, favoring Ipi-Nivo. At 12 months they were statistically apart. At 18 months they came together a little bit, and then the median follow-up's only 2 years. I think if you just look at the Ipi-Nivo data by itself, not even thinking about the comparator, immune therapy, Ipi-Nivo is active in non-clear cell, broadly speaking, papillary being the majority of what was enrolled in this trial. I think it's recapitulating the debate of IO versus IO-TKI in clear cell, right? It's almost the same thing. If you're an Ipi-Nivo giver, you look at this and you say, yeah, there's activity, it's better than single-agent TKI, maybe there's going to be a tail of the curve, we don't know that yet. And so I'm going to use this because it's my best chance for durable response, or as David would say, a treatment-free survival and remission. If you're an IO-TKI user, you say, oh, okay, this reinforces that, yes, IO is active. We know from the single-arm IO-TKI data with Len-Pembro and Cabo-Nivo and some others that there's high response rates, 50, 60%, right? Single arm, so all the caveats. So I think it probably reinforces what you were already doing in non-clear cell. I don't think single-agent TKI is a standard of care in papillary or any non-clear cell, honestly. I haven't felt that way for a while, and I think these data just reinforce it. But as you say, it's practice informing. I think it's good. To do a randomized trial in non-clear cell is really challenging, so kudos to them. And I think for me, it reinforces, I give IO-TKI up front. Would I give Ipi-Nivo? Yeah, I think so. Sarcomatoid for sure, if there's any sarcomatoid element, but I probably still would lean IO-TKI.
I probably would too. At our meeting, we had a podcast on papillary renal cancer, and I think it was a good discussion. And I think the community is debating where we are in terms of Ipi-Nivo, but I think people now agree, because I've been saying to date there isn't that much evidence to support going better than single-agent cabozantinib or sunitinib. And I know that's controversial. I did that intentionally because I thought the data set...
Sure you did.
Because the data...
In retrospect,
I was right, because I changed my mind. I think Winston Churchill said, history will treat me fairly because I'm going to write it.
That's pretty good.
He knew what he was doing. I think with this, just speaking frankly, I was sceptical that we weren't collecting enough robust data sets in papillary renal cancer to reinforce a big change for combination therapy. Because giving combination therapy is a big change from monotherapy.
Agreed.
And we were having a few patients here and a few there, and we weren't really sure immune therapy was active. We've now got randomized data, so even in the papillary cohort, immune therapy is definitely doing something.
Yeah.
And therefore, giving Ipi-Nivo is fine. I think giving Len-Pen or Cabo-Nivo looks more attractive to me from a distance. Yeah. So that's why, and I got criticised at our meeting for saying I think the Ipi-Nivo data actually supports Len-Pen bizarrely.
Yeah, I'm still not quite sure I understand.
I'm right.
That.
Go back and listen to the podcast. Yeah, it'll be really clear there.
Important data, and I think the question is now, where do we go, right? There's still other targets we're missing in non-clear cell, right? I'm sure there's other biologic targets.
Well, one of those is the MET target, and we talk about savolitinib and...
So there's some MET targeting agents. There's a phase 3 called SUMITA with that's savolitinib based with durvalumab, sunitinib control. So we'll see as that data comes out. I've been unconvinced about the role of MET in papillary kidney cancer for a long time.
Yeah, I'm convinced.
I know all the data. I know you can show to this staining and blah, blah, blah.
Yeah.
For sporadic kidney cancer, not germline. I think germline is different.
Huge response rates, massive PFS.
We'll see what the randomized data show.
We will indeed. We're very excited about it. There's also a second generation VEGF TKI, nivolumab.
Zanzalintinib Nivo versus sunitinib. It's called Stellar 304, I believe.
Some people say to me, we shouldn't be doing some of these trials because the control arms aren't right. By the way, these new combinations aren't globally available. They are available in the US, but I think so LEMPEN is a single-arm data set, and so much of the world is still using sunitinib. If we do these big sunitinib trials, and we beat it significantly in big randomized trials, all the criticism I've had in the past will go away. Suddenly, in papillary renal cancer, we've got really good randomized data to support this evidence. So taking part in these studies remains important, Brian.
Agreed. Totally agree.
You can't enroll in the US and that's okay, but in those countries where sunitinib is still the standard of care, this is more attractive for patients.
Yeah.
So
I don't know. I totally agree with that. How about Nivo? You want to talk about?
No, I'd like to talk about sequencing therapy in the Uromigos part. I'd like you to talk about HIF inhibition right now.
HIF inhibition, so...
because we saw some new HIF data, and we saw you presented the updated OS data for 005.
I did. So belzutifan approved in the US late last year, actually first presented at ESMO 2023. PFS advantage in a refractory, VEGF and PD-1 refractory kidney cancer population compared to everolimus. Interesting PFS curves, together through the median, almost an immune therapy type curves, together through the median, I think it was 5.6 months. But then the belzu curve clearly separates, and the landmark at, I think it was 18 and 24 months in the original presentation was clearly different and better for belzutifan. And sort of screams that there's a select population of patients that's going to do well with this drug long term. We haven't seen biomarker data yet, but that's clearly needed. There was not an OS advantage at the time. It was interim. We then updated that at ESMO this year, and the PFS and response rate signal persists, not surprisingly. There was not an OS advantage. Hazard ratio is 0.92, so lower than 1 for what it's worth, and a difference in the medians, but not significant. We've talked about the tolerability of belzutifan before, so I think the PFS advantages, that we see, the tolerability, the fact that your other choices, chronic TKIs, which nobody likes, and especially patients, and is very toxic. I think yes, of course we want to see OS, right, of course. But I still think the data reinforce the role for this drug in this refractory setting as we wait for combination trials in the second line and front line and even adjuvant setting. That's a whole nother discussion, but those trials are coming. But for now, it's, I think, a third, fourth line drug.
I agree. What about the second generation of HIF inhibitors?
Yeah, so we saw Eric Yonash presented some data about another HIF inhibitor, NKT, and I'm forgetting the numbers.
NKT's fine.
Thank you. But I think what we've seen from other HIF inhibitors broadly is, at least for the small molecules, for this small molecule, it had belzutifan-like activity. Refractory setting, response rates in the 20%, et cetera. Has a very long half-life, 38 days. We
did a podcast with Brad McGregor, and there was a discussion about whether they've actually got the right dose. Do you remember all the double site?
They're doing loading dose and this and that, so they're still very much in that dose exploration, schedule exploration phase. But yeah, I think...
Do we need a second HIF inhibitor?
I don't see why not. I have concerns about the long half-life from a toxicity perspective, not efficacy. But just like it's nice to have more than one VEGF inhibitor, right? Because they can work in sequence. Whether that's true of HIF inhibitors, we don't know yet, and it may not be because they're more specific. But yeah, I think there's always room for more active drugs, right, as a general statement. Monty had presented some Novartis HIF inhibitor data earlier, which didn't look as active, but they didn't really get to active doses, so I'm not really sure what to do with that. There was actually a publication by Jim Rugerlis on a siRNA interfering HIF inhibitor, which had some activity, but also had some neurotoxin and other toxicity, so won't be developed. So I think the belzutifan data, 005 and otherwise, is the very beginning of this HIF inhibitor story in kidney cancer. And whether it's better early, whether it's better in combination, whether other drugs will have advantages even, PK or PD or otherwise, I think it'll play out over the next few years.
ESMO was a big meeting, I think, for all three cancers.